السلام عليكم. اسمي خالد زغلول، أستاذ مساعد جراحة عظام. والنهاردة we're going to speak about the very common topic, which is called the limping child. So what's limping? It's uneven, jerky gait. So any change from the normal gait is called limping. And it's mainly caused by three factors: pain, weakness, and deformity. And one of the most common complaint for visiting an orthopedic clinic. And because the etiology can vary from benign life-threatening conditions, and the management as well varies from just reassurance to a major surgical procedure. As we said before, three factors can cause the child to limp. It's pain, weakness, and structural or mechanical abnormality. And why we're discussing limping, especially in children, because children, most of the time, they can't give us a full history. So it's our job to find out the etiology for why this kid is changing the gait. This slide is busy and it's not meant to memorize all the factors and the causes for the limping, but it's the same mnemonics that we all use for a disease. It's traumatic infection, neoplastic or vascular or inflammatory. So it's a wide variety of etiology that cause the limp. One of the issues which can help us to figure out why this kid is limping is a very small piece of information, which is age. And from this slide, you can give us or realize how much the age can stratify the etiology depending on the age. This is a more smaller version of the previous table, in which when the kid is from 0 to 5, infection is one of the etiology. From 5 to 10, we have a disease called Perthes disease. Perthes disease, it's a disease where the blood supply of the head is reduced for unknown etiology. Or from 10 to 20, slipping of the upper femoral epiphysis can be an etiology as well. Slipping is a disease as well, where the upper femoral epiphysis is moving from its normal position at the top of the head of the femur, and this causes the kid to limp as well. I'm emphasizing more on the history, which is a very important practice that you should train yourself on, is taking history. It's like an art, because a lot of the mystery of the diseases can be breaked out with digging into the history. So by asking simple questions like, is this limp is painful or not painful? Where is the pain? How long is this pain at duration? And if this limp is related to activity or it's not, and number of joints involved, and any associated symptoms like fever, weight loss, anorexia, or back pain, so like systemic manifestation. Because all these items, it's very important. So like one of the words that I can hear from the mother or the parents, if this pain aroused the kid from sleep, so this is what we call the pain at rest. So pain at rest is something we should consider. So it's something serious, more than pain related to activity. Continue with history. So recent history of viral infection, like post-infectious arthritis, or any GI symptoms, or any activity or related to sports. Some of them can have stress fractures, or any history of intramuscular injection, any endocrinal dysfunction, or any family history of similar condition. So all these are history. The history is very important to emphasize, and in this slide, it's only a key points that it can point to you what etiology can be revealed by looking at the history only. The red flags in taking history: if a kid less than 3 years presented with limp, this is a red flag. So if a kid is unable to bear weight, so this is a red flag. If it's associated with any fever or systemic illness or systemic manifestation like weight loss, so this is a red flag. Those are the items that we should consider when we are taking the history. So moving to the physical exam, so the gait is a cycle. So meaning that it's a repeated cyclic movement. The gait can be divided in two phases, the stance phase and the swing phase. I'm not going to go through all the phases, but the idea is we are moving with 2 feet, and we have a part of our gait cycle where both feet are touching the ground, and there is one gait cycle where the feet is one feet is up in the air. So this gait cycle, by changing one of each point or steps in the gait cycle, can end by any gait abnormality. So there is normal gait variation in kids. So there is a development of how the kids are walking, and the normal variation, as in when the kids start to walk by the age of 1 year. So they start by a tip to walker. So they walk on a tippy toes, or they can walk when intoeing. So the big toe are pointing inward, and this can persist till the age of 8 years. And most of the time this is a normal variation due to a femoral anteversion, so increasing the angle of the neck of the femur in relation to the shaft of the femur. Or sometimes they can have what we call the metatarsus adductus. It's the same condition where the big toe is pointing inward, and sometimes it needs some treatment, but there is a lot of time that it can resolve spontaneously. Continuing with normal variation, the bow legs were what we call the genu varus. Genu means in Latin the knee. Varus, where the tibia is pointing inward. So there is a space between both knees, and this can be considered normal till the age of 3. Or the knock knee, where the two knees are touching each other, and there's a space between the two malleoli, and this can be corrected as well by the age of 7 years. Flat feet, and kids walks with a flat feet, this is considered normal in a lot of kids, and most of the time it can be corrected by the age of 6 years. Moving to the pathological gaits, the pathological gait, where there is, as we said in the beginning, it can be due to a muscle weakness or a deformity or a neurological disorder. So in the next couple of slides we are discussing a couple of patterns very common in gait cycle where it's a pathological. So one of this is the antalgic gait. So we all had trauma to our ankle, or we have seen some of our relatives have any kind of trauma, and when there's something painful in our lower limb, the gait that we are presented is called the antalgic gait. So antalgic, so the body is trying to avoid loading the painful part of this body. So this antalgic gait is due to any painful stimulus in the lower limb or the pelvis. So the body is starting to shift the weight on the painful limb very rapidly to avoid loading this part. The other gait is called the Trendelenburg gait. Trendelenburg is the name of the scientist that described this, and this part is due to weakness in the abductors, like in poliomyelitis or muscle dystrophy. And this at this part of this gait, the pelvis is shifting or tilting when the body is loading this diseased part. The other gait is the gluteus maximus gait. This is when the gluteus maximus muscle is being affected, so the body is leaning backward when they are walking, and this is very characteristic in poliomyelitis. The quadriceps gait, it's seen also in poliomyelitis, and we have realized it if you recognize one of the people walking the street with a polio and they are supporting the knee where the quadriceps muscle is weak, and to avoid giving away of the knee while the patient is walking, they put their hand on the kneecaps or the patella to avoid giving away of the knee. So this is called the quadriceps gait. The other gait is steppage gait or drop foot. So when there is an injury for the sciatic nerve, there is loss of the dorsiflexion of the ankle, and because of this there is plantar flexion of the foot and the ankle, and to clear this foot from the ground, the patient will raise the knee high up to avoid slapping the ground. So this is called the steppage gait or foot drop gait. One of the things that cause the abnormal limp is the short limp gait. So the shortening can cause a dipping of the pelvis, as we have seen in the previous slides under the Trendelenburg gait. So by a physical exam, we want to know what is the reason for the limping child, what causes it. So physical exam starts by examining the child in standing. So the back should be examined for scoliosis, which is deviation of the spine or any tenderness, and looking at the pelvis to check if there is any trend, if there is any tilt. Where this can be managed or measured by placing the block under the shorter leg. So if there is a leg length discrepancy and one limb is shorter than the other, so the pelvis will tilt, and putting a block under the short limb will correct this as well. And by examining them supine, so each joint should be examined separately, and we're looking for any swelling and tenderness and range of motion, and as well checking again for the leg length discrepancy as well. Examination start by looking for both sides, so asymmetry in the abduction. This is a clue for limited range of motion of one hip rather than the other side, which is very common in developmental dysplasia of the hip. Examining the patient in prone position can give us an idea about the rotational alignment of the lower limb, and this can be one of the clues for the internal tibial torsion and increased femoral anteversion. The Galeazzi test, it's a name for a test where it's a method where both kneecaps should be looked from the front and the side to check if those caps are at the same level, and this can check for the leg length discrepancy as well. So, and don't forget that intra-abdominal pathology and any testicular torsion can be presented with limp as well in kids. So if you have like an appendicitis, it can present with an abnormal gait as well, so examine the abdomen. Moving to the investigation, it carries all the hematological lab investigation from the CBC, CRB, and one of the important criteria for detecting any septic arthritis in the joints is the Cooker criteria. So the Cooker criteria, when to detect there is an infection in the hip, is fever more than 38, or can't bear weight, or ESR more than 40, and white blood cells more than 12,000. And the probability of septic arthritis would be 0 if only one of them is positive, would be 0. If one criteria is 1, if 3%. If 2 criteria is 40%, 3 criteria is 93%, 4 criteria is 99.6. The septic arthritis is probable to happen. Blood culture can be used as well, all this for infection detection, and the coagulation profile. Sometimes if you have like a hemophilia and there is knee arthrosis or hemoarthrosis, it can be detected as well by lab. One of the methods to evaluate the limping is to aspirate the knee and to analyze the synovial fluid. And by analyzing the synovial fluid, it can differentiate between different types of knee arthritis, inflammatory, septic, or it's a hemorrhagic arthritis. Moving to the radiology, so the X-ray is very important because there is a lot of injuries that can happen, and with a supple mode of trauma like the tubular fracture or any stress fracture, so plain X-ray is important, and signs of effusion like in this plain X-ray. So you can recognize on the left side how much is the hip joint is space is widened in comparison to the other side, and you can recognize the septic arthritis in X-ray as well, but it's in a later stage, and this can be detected by the osteopenia and narrowing of the joint space. But the hallmark of the septic arthritis is evident in more neglected cases. In kids, there is a lot of syndromes called the overuse syndromes. The kids are machines for playing, and all the time they are playing, so they have a lot what we call apophysitis. So the apophysis, it's attraction epiphysis. So like in the calcaneus, in the proximal part of the tibia, all these are called the apophysis. And attraction apophysitis is very common cause of pain in growing child. The slipped capital femoral epiphysis, what we abbreviated the SCFE, it's one of the diseases that can happen in kids with hormonal imbalance, in which the upper femoral physis is not resting in center of the neck, and by having this slip, there is a decreased range of motion of the hip and limping as well. Perthes disease, it's a disease that affects the hips in growing age, in which the blood supply of the hip is reduced, and by having reduction of the blood supply of the head, there is a collapse and shortening, and by this the hip can the gait change to be a limping gait as well. One very important thing is examining the back. So discitis or inflammation in the disc is very common to happen in children as well and be presented with the limping. So doing an X-ray for the back is one of the tools to elaborate the etiology for changing of the gait. Continuing with the radiology, so the ultrasound is very important to detect the septic arthritis, and it can be used to evaluate the widening of the epiphysis and the joint space, and it can help as well if there is a fluid. The radiologist can aspirate the synovial fluid, and by this you can analyze the synovial fluid and differentiate between the inflammatory and the septic arthritis. The CAT scan can help us in in diagnosing a lot of the pathology, like in slipped capital femoral epiphysis or any infection in the spine or the retroperitoneal region, for example. MRI can be evaluated as well for a lot of diseases like Perthes disease, discitis, or any leg pain or tumors. Those are the tools that can be used to evaluate the limb. And still, there is a rule for a bone scan. And the bone scan, one of the things that can give you us an idea about any abnormality happening in any part of the body, if there is overactivity like infection or tumor, so it can help us to differentiate between both diseases. So the take-home message is acute limp in a child should be taken seriously, as it can be a serious underlying pathology. Age of a child is important when considering the most likely etiology. If trauma has occurred, there is a lower threshold in performing an X-ray in children, as fracture and dislocation are more common. For atraumatic limp, the red flags, age less than 3 years, inability to bear weight, systemic illness and pain-restricted range of motion. In child from 3 to 9 who are well with no fever and able to bear weight, and less than 48 history of atraumatic limp, transient synovitis is usually the cause. Suspect the slipped capital femoral epiphysis in a limp for more than in a kid more than 10 years of age, and the Kocher criteria is very useful to distinguish the transient synovitis, which is non-septic inflammatory process in the hip, from the septic arthritis. Thank you very much. Thanks.